You're always gonna do the same process in every joint every time. So we're gonna inspect, palpate, check our range of motion, do our strength testing, check for stability, and then do any special tests. So on your rubric, you're gonna make sure that you introduce yourself, wash your hands, do a quick review of systems. I'm just gonna do one side and you do both sides always. So we're gonna start with your shoulder. First thing we're gonna do is we're gonna inspect it. We're looking for any ecchymosis, any atrophy, any deformity, any asymmetry. We don't see any. Then we're gonna make sure that we check the back and look for, again, any atrophy of the supraspinatus or the infraspinatus or the deltoid. And then we're gonna palpate, and we always palpate with a purpose. So we're palpating structures that we know where they are. So I'm always gonna start with the sternoclavicular joint. And then we're gonna palpate laterally. And I'm gonna find the AC joint by palpating the little V behind the clavicle and coming forward. And just lateral to that's the hard acromion. If we go more posterior, we're gonna palpate the scapular spine. And then right off the front of the acromion is the supraspinatus tendon. And then I'll take control of the humerus and come a little more distal, and I can feel the bicipital groove. And I know that's the bicipital groove by gently internally and externally rotating the humerus. I can feel the lesser tuberosity, the bicipital groove, and the greater tuberosity. And then I'll keep coming medial, and I'll find that very hard and stable coracoid, which is tender in everyone, but it doesn't move. So after we're done palpating, we're gonna check our range of motion. So I always start with external rotation. So I have them externally rotate their arm actively. Normal is about 70. Then I ask them to reach up behind their back like they're gonna scratch their back. And this is internal rotation. So a normal would be to the inferior border of the scapula, which is T7. And then I ask them to abduct the arm, so elbow straight, and you're gonna bring your arm straight out, up over your head. So that's 180. And then with your arms back down to your side, you're gonna come straight up. This is elevation all the way up over your head, and that's 180. Bend your elbows. Now I'm gonna check for strength, and I'm gonna check in the same ranges of motion. So I'm gonna push out against me. That's external rotation is 5. Pull your hands together. Internal rotation is 5. Abduction, push up towards the ceiling. That's 5. And then elevation, push up towards the ceiling, and that's 5 as well. So we've inspected, we've palpated, we've checked our range of motion, we've done our strength testing. For stability, we're gonna do what we call an apprehension test, where I abduct the arm, externally rotate, and asking if there's a sense that the shoulder is gonna come out. If they do, then I'm gonna push posterior on the humerus, which is gonna give us a relocation sign. Okay, and then any special test, what we're looking for with impingement will be a near impingement test. So I ask them to turn their thumb down, raise your arm up over your head, bring your arm back down. So if that creates pain, that would be indication of impingement. A Hawkins impingement test, the shoulders flex 90, and we interrotate the humerus, again eliciting any pain in the shoulder. A Speeds test, the forearm is supinated, the elbow is straight, and we're flexing the shoulder, and I'm resisting that, and we're looking for pain on the shoulder along the biceps. The Jurgensen's test, the elbow is now flexed 90 degrees, slightly abducted in the shoulder, and we're resisting internal rotation. So again, looking for biceps instability and pain. We discussed the Fulcan test, the thumbs are up towards the ceiling, push up towards the ceiling, looking for pain. This is the empty can test, same thing, push up towards the ceiling, looking for pain. I think those are all of our special tests. Now we're gonna go to the elbow. So same thing, we're going to inspect the elbow. I'm looking for any deformity, ecchymosis, the contour of the biceps, any atrophy or skin changes, and I see none. And then we're going to palpate. So I start laterally, I'm gonna palpate the lateral epicondyle, and then just distal is the radial head, and I know what that, by supinating and pronating, I can feel it rotate. Then we're gonna palpate the radial capitellar joint or the soft spot looking for a fusion. Here's the olecranon bursa, triceps tendon insertion. And then medially we're going to palpate the medial epicondyle, and then just posterior to that's the ulnar nerve. We can palpate that. While we're there, we can do a Tinel's where we tap and elicit any pain or shock in the distribution of the ulnar nerve. Now we're going to check our range of motion. So here we have extension. This is she hyperextends, so we call that -10, but normal is 0. We flex, normal is 140, she's about 150. I bring the elbow to the side, so I take out the shoulder, and now our supination is 90, pronation is 90. Now we're going to check our strength in the same ranges, so pull toward your hand towards your face. So flexion is 5, extend the elbow, extension is 5. And then supination and pronation, I hold the hand like we're shaking hands, push your palm down, and then pull your palm up. Good. Stability testing in the elbow, typically I would just have them relax. I stabilize the humerus and I give a varus and valgus stress. The milking test, or the moving valgus stress test, we're looking for the medial ulnar collateral ligament pain. So this is a milking test where I'm actually externally rotating the shoulder with the elbow flexed 90 degrees. A moving valgus stress test, I apply the same force, but I take the elbow through an arc of motion, and the patient will complain of pain over the medial side of the elbow from about 60 to 120 degrees. That often hurts the shoulder. Okay. Special tests in the elbow, we're going to just check for tennis elbow and golfer's elbow. So we check for wrist extension. So I have you resist me. So wrist extension will create pain over the lateral condyle in tennis elbow. And then the same thing, wrist flexion, resist that. If that creates pain medially, that's golfer's elbow. So that's the elbow exam. Now we're going to go to the wrist. So same thing, we inspect the wrist, looking for any deformities, any ecchymosis or atrophy. We see none. Now we're going to palpate. So we'll start with the distal radius and the radial styloid. We feel the ulna and the ulnar styloid. We can feel the radial carpal joint. Right here we can palpate the snuff box, which is the scaphoid. And then as we turn more volar, we can palpate the pisiform and the hamate. While we're here, we can do a Tinel's because it's easy to do. I tap the median nerve looking for any dysesthesias or paresthesias in the median nerve distribution. So we've palpated. Now we're going to check our range of motion. So flexion is about 90, extension is about 80, and we're going to do radial deviation about 40, ulnar deviation about 20. Strength testing, same thing, hold your wrist up, don't let me push down. Pull your wrist down, don't let me push up. Push against my hand here, that's the ulnar deviation. Pull your wrist this way, that's radial deviation. Then we'll check strength in the hand itself, so we check the dorsal interossei. Hold your finger straight, don't let me push down. Okay. Now we're going to check your thumb, hold your thumb up, and then pull your hand together, don't let me pull your fingers apart. So that's your dorsal interossei. Now we're going to do any special tests. So we already did a Tinel's. We palpated this snuff box for the scaphoid. We do a compression, load and compression test along the thumb CMC joint. And we'll do a Finkelstein's test where I have you grab your thumb, pull that in, and we radial or ulnar deviate and radial deviate, and we're looking for any pain along the extensor tendons here or any crepitus. And the only thing I did test was for sensation. So